Next session will be State of Art Lecture chaired by Dr. Shuichiro Shina, Japan.
Okay. So can we start now? Okay. So it is a great honor for me to moderate this state-of-the-art lecture by Massimo Colombo, professor of, in Italy. So Professor Massimo Colombo will give us a lecture titled Toward the Risk Stratification Screening of Hepatitis C-Related Hepatocellular Carcinoma. Professor Massimo Colombo, please. Oh, hello.
Good afternoon, ladies and gentlemen. Dear Chairperson, I wish to thank the Scientific Organizing Committee for having me here discussing on hepatitis C-related liver cancer screening program. These are my conflicts. Liver cancer due to hepatitis C is a real burden. It kills more than 150,000 persons per year. And owing to the fact that there is an expanding population with heterogeneous risk factors that include the restless accumulation of people with the cure AC virus, those with diabetes, alcoholics, obese population, in general, those with metabolic risk factor, it has become imperative refining criteria for cost-effective risk stratified algorithm. To achieve this goal, we actually need having high-precision molecular tests for liver cancer that unfortunately are not available due to the fact that comprehensive tumor molecular data remains elusive in this form of cancer due to the infrequency of tissue biopsies. Liquid biopsies might serve the scope of obtaining data from circulating tumor components like proteins, DNA, RNA, extracellular vesicles, which might favor early diagnosis and why not help in building up risk-based algorithms of surveillance. However, these are associated with challenges related to sensitivity and mainly to cost. In the last year, there has been an evolution in the concepts of cost effectiveness of HCC surveillance, which strictly depends on the incidence of liver cancer. Currently, US plus alpha-fetoprotein are the standard of care to run HCC surveillance with a high specificity, but unfortunately with disappointing sensitivity. Risk stratification of the target population is grounded on liver disease severity, but has many pitfalls. AGA developed criteria some 50 years ago to define a cost-effectiveness threshold of HCC incident for screening for HCC cancer, paying $50,000 for a disability-adjusted life years averted. The cutoff was set at 1.3. The cutoff was downgraded to 0.8 in the very last years when the willingness to pay rose to $100,000 per daily, and 2.7 more recently in the virologically cured patients, still with the willingness to pay $100,000. It should be, however, reminded that in certain areas of the world, Europe, for instance, there's a huge heterogeneity in terms of gross domestic product. And there, of course, you need to have something standardized, like WHO criteria, which define cost effectiveness, whatever is done at the price, at the cost of 1-3 times the GDP. In Italy, 3 times GDP means $100,000, basically. The International Liver Society recommends starting surveillance of patients with hepatitis C from the fibrotic stage of METAVIR 3, advanced fibrosis, with the exception of a puzzle that recommends starting screening in patients with lesser fibrosis in the liver, however, who have been cured with DAA, because the study revealed the coexistence of F0, F2 stage in 28% of patients with liver cancer. Screening is performed as usual with ultrasound every 6 months. A puzzle wants to use also all the panel of tumor markers, FP, FP3, DCP, ESOL, just ultrasound, ESOL-D, a combination of ultrasound plus alpha-fetoprotein. At variance with ESOL and a puzzle, ESOL-D recommend against screening all patients with acute hepatitis C. No very big nuances in the surveillance of patients with cirrhosis that can be diagnosed either clinically or histologically, or however, it is been usually done in the past 5-10 years using surrogate markers of liver disease severity. FibroScan at a cutoff between 12.5, 13 kilopascal, or FIB4 at a cutoff greater than 3.25. Surveillance is recommended in patients with acute hepatitis C. However, making diagnosis of severe liver disease using the surrogate markers of liver disease severity like FibroScan and the FIB4, you incur in a number of flaws because these two markers have a suboptimal positive predictive power, 60%, in the range of 60% FibroScan and in the range of 55% FIB4, whereas they have a good negative predictive value. Altogether, this account for the fact that there are limitations and challenges in the current criteria of developing re-stratify surveillance strategies, and the barriers most often encountered is the inadequate re-stratification, as we said, and the availability of suboptimal accuracy screening test. In certain areas of the world, also under rules of surveillance plays a role. So the way out is developing re-stratification algorithms and developing biomarkers to better identify patients at risk of developing liver cancer. Dr. Nahon, some years ago, proposed such an algorithm. If we were to use appropriate means and obtain specific threshold of HCC incidence that help separating low-risk population, intermediate-risk population, and high-risk population, the low-risk people should undergo the classical recommended US surveillance every 6 months, whereas the high-risk population would deserve better optimized surveillance modalities that include the use of CT scan and MRI as a screening test instead of US, and the use of biomarkers for early detection. The use of shorter intervals is highly debated because many experts feel that the risk of developing cancer does not correlate with the rate of tumor growth. Those in intermediate, so-called gray area individuals, intermediate HCC risk, should undergo reinforced US surveillance with educational programs directed to doctors and nurses, mail outreach to improve compliance, and dedicated clinical pathways to be generated indoor and outdoor. Luckily enough, we are developing a number of biomarkers that would help us in better identification of tumor and anticipating tumor identification prior to the imaging diagnosis. On top of this is the old alpha-fetoprotein, which is regarded as a degenerated albumin, which is the only biomarker that has been validated for its impact on prognosis and prediction of mortality in the setting of tumor resection, tumor transplantation, and more recently, systemic therapy. Genomics include cell-free DNA genomics and epigenetics. Let's think about methylation. Extra cellular vesicles that bring around in the blood a number of information, microRNA, DNA, proteins, expression of pro-tumor proteins, metabolomics, and circulating tumor cell. Unfortunately, there are barriers to the development of HCC marker, mainly due to the molecular histological heterogeneity of the tumor. But there is some methodological flaws, like the fact that the outcomes in liver cancer are time-dependent, and that there is no linearity in the behavior of cancer, whereas biomarkers follows the rules of linearity. We need calibration, and in the end, we need, for the sake of translational medicine, external validation, bringing to the West what has been developed in the East. In the end, we are still in a gray area represented by the fact that so far, all these markers that we are going to discuss have been investigated in phase 1 to 3 biomarkers trials, whereas we need phase 5 biomarker trials, the randomized clinical trials that would validate that that specific marker is one applied in a re-stratify algorithm is able to decrease HCC-related mortality. I wish to start the journey throughout the new algorithm with GALAD because it has been designed as a food and drug breakthrough device it was found to have a powerful ability to identify early stage cancer, 0.9, with, however, a sensitivity of 73.8% in a variety of etiology of cancer. Down in the slides are the hepatitis C-related cancer, where you can see that sensitivity rose to 0.86 with a specificity very good, 0.89. And in terms of area under the curve, fantastic, 0.94. However, moving from this meta-analysis to a study in a cohort of patients at high risk of developing cancer, like the veterans, that are all males. They have cirrhosis related to multiple risk factors: alcohol, obesity, diabetes, hypertension, drug abuse, and viral hepatitis. The GALAD was found to have a poor predictability, 42%, the rate of true positive result when specificity was set in a competitive manner at 90%. No better than other algorithms like AGE-ES, age-ALT platelet count, percent change of alpha-fetoprotein level, and alpha-fetoprotein L3 alone. Better performance was done with the algorithm developed by Professor Semmler in Vienna. This is a multi-center study in various regions of Europe, focusing on patients with compensate advanced chronic liver disease due to hepatitis C that achieve also an SVR. And here you see it was able to separate the low-risk population, 0.9, from high-risk, 0.4, by accumulating demography, age, liver disease severity, albumin, and FibroScan, liver stiffness, and alpha-fetoprotein greater than 4.6 nanogram. Very good. Alpha-fetoprotein stands as a pillar of this new algorithm, not only in GALAD, not only in Semmler, Dr. Semmler algorithm, but also elsewhere. And this is a list of the new biomarkers that are being investigated as a liquid biopsy platforms and are engaged in study of phase 2 to 3. The most promising ones are the cell-free DNA of genetic alteration that have to do with carcinogenesis coupled with gender age, demography, alpha-feto, and DCP. 100% of sensitivity versus 94% specificity. The problems? Underpowered. 24 cases of HCC, and not all of them are HCV related. The other good one is the Dawley's-Town algorithm: age, logarithm of alpha-fetoprotein, PEG-precipitated IgG, and fucosylated kininogen proteomics. 90% sensitivity for early cancer and 95% specificity. This is much better, and this power, 115 HCC. Very disappointing, on the contrary, are the extracellular vesicle, only 8% sensitivity for early HCC. Alpha-fetoprotein has been also applied to another early stage predictor algorithm, the so-called HCC check, where two proteomics, CK1 and EMI, were coupled with albumin and alpha-fetoprotein. And there you see that for a cutoff greater than 2.56, the area under the curve was 0.97, the sensitivity was 90.7% versus a specificity of 91.2. Here, you might say that the algorithm fits perfectly our aims because it was run in a country, the Egypt, where the vast majority, 90% of liver cancer are hepatitis C related. And it is user-friendly because it is measured through Western blot and ELISA. But there is another more user-friendly way of testing for a prediction of HCC, and is the dosing, assessing the urine content of circulating tumor DNA, like mutated TP53 and methylated RASSF1 and GSTP1. Using this approach in patients with cirrhosis and various etiology of liver disease, the urine panel itself was surpassed by serum alpha-fetoprotein in terms of sensitivity, definitely. But the urine panel was able to identify half of the tumor that were not detected by alpha-fetoproteins. And when alpha-fetoproteins was combined with the urine panel, it was able to identify 80% of the HCC cases, not all, of course, early. And the early stage ACC, however, detected by the compound alpha-feto urine panel rose from 62% to 92%, BCLC stage 0, very early, and from 40% to 77% in Barcelona stage A, so very promising. And this study was run in a developed area of the Americas. Unfortunately, the circulating tumor cells are of no help in this specific situation because they correlate with tumor size and the level of alpha-fetoprotein. So they are perfect for staging, for testing for recurrence, but they suboptimal, I would say useless in terms of screening for early detected cancer. Dr. Nahon, a few years ago, developed a study which was able to identify patients with a high risk of developing liver cancer, more than 3% per year, versus those with less risk, using an algorithm that was composed by demography, age, sex, disease severity, platelets, GGT, bilirubin, and the pillar alpha-fetoprotein. Using a Markov modeling, it demonstrated when high-risk population, which was a minority, 1/3 of the overall population, of this population, which included 1,500 of patients with acute hepatitis C, were investigated with the reinforced surveillance MRI every 6 months. They were able to detect 63% of a very early HCC, stage 0 of Barcelona, at a cost that was exactly the same used to detect the 14% of very early cancer in the patients under surveillance with a regular ultrasound that have a low risk of developing cancer. And in the end, in terms of ICER, this approach was judged to be cost-effective. Everything we have discussed has been made possible because patients with a high risk of developing liver cancer can be subjected to inoffensive modality of diagnosis HCC and detecting early HCC. Low-dose CT scan has been used in South Korea, and it proved to be more sensitive than ultrasound. But that study has many flaws. It's underpowered, 27 cases of HCC, and to me is rather unbelievable that ultrasound in the hand of such an expert hepatologist like the South Korean colleague was able to detect liver cancer only in 29% of the investigated population. More comprehensive evaluation through a meta-analysis of the performance of abbreviated MRA, contrast or non-contrast, able to detect less than 2 centimeter cancer in 69% of the cases. And the good news is that contrasted and non-contrasted at a similar performance rate. And this is an important point because MRI contrast is thought to accumulate in the nervous system and may provide toxicity. So in the end, ladies and gentlemen, and the chairperson, we dispose of modalities to implement a risk-stratified algorithm for screening of liver cancer, new imaging performance techniques, blood biomarkers, and why not urine biomarkers. I personally believe that the GALAD algorithm is still, the jury is still out for it, but altogether, these modalities of investigator have to go through the next step in search of a validation, demonstrating they are able to decrease an HCC-related mortality. In the end, let me pay a tribute to Professor William Osler, who was the founder of the disciplines of internal medicine, and together with other colleagues of him, the founders of Johns Hopkins Hospital. He used to say that medicine is a science of uncertainty and an art of probability. And our journey through risk-stratified surveillance algorithms and the art of predicting the future is a proof of it. Thank you very much for your attention.
Thank you, Professor Massimo Colombo. So thank you very much. I met you maybe 30 years ago at the University of Tokyo. I remember you. Thank you. And I also met you so many times in international medical conferences. And we think we aim for APASL 2024 to be the final step for elimination of viral hepatitis and liver cancer. So we still have some minutes. So are there any questions or comments from the audience? Yes.
Hi, Massimo. I'm not sure if you can see us or not. It's Simone Strasser from Sydney. Nice to see you. I'm just wondering what you're thinking. Here we are. Hi. In terms of course, we want to go for increasing sensitivity when we're doing screening, but we also want to apply the test to as many people as we can in a population. And certainly in many of our countries, in particularly in Australia, where we've got big scattered geography and a lot of people living in remote areas, we want the easiest test to be able to apply to the most people at the lowest cost. What do you think, projecting ahead, that's going to look like in a few years in terms of effective screening tools applied to a population that's scattered and has multiple etiologies, including prior hep C?
Yeah, thank you for your question, and good afternoon to Professor Shina, and thank you so much for having me dealing with you on this specific topic. Well, I think that taking outdoor the screening program is mandatory if you wish to be impactful in an area where there are many, new cases of liver cancer developing in consequence of metabolic syndrome and alcohol abuse. This is, for instance, is going to be at least in my place in Milan, they are becoming the leading reasons for listing patients to liver transplantation. So they have surpassed hep B and hep C. You are perfectly right. And at that point, I think that the urinalysis, so validating those tests in the urine, and in case we are able to demonstrate that there is a reduction, a substantial decrease in liver-related mortality using this urinary test, I think that would be the best way to bring screening program outside hospital places. And then, of course, reminding all of us that the final diagnosis required, though, specialized centers, not to depend on outdoor, let's say, out clinics and something like this. So broadening the outreach of the population at risk of developing cancer with a urinary-based test and bringing them in specialized center for the final diagnosis, and even more so for treatment. And what is difficult to achieve in Italy is to, handle patients with liver cancer in specialized centers where the full pipeline of intervention are available, going from radiotherapy to local ablation to liver transplantation. Yeah.
Great.
Are there any questions or comments? So thank you very much, Professor Colomba, for your very stimulating lectures. So see you again in the near future. Thank you very much.
And thank you to all of you. It was a great pleasure to be with us. Have a nice day.
Thank you very much, the lecturers and moderators.